This is Learning Plan 8, High Risk Perinatal, and this class recording is focusing on infection. The reason that infection is such a high-risk situation for a pregnant woman is that infections in pregnancy are responsible for a significant amount of morbidity and mortality in this situation. Some consequences of maternal infections actually last a lifetime, can cause infertility and sterility. There are a lot of psychosocial aspects to it, and those psychosocial results may include altered interpersonal relationships and lowered self-esteem, especially if they are sexually transmitted infections. And congenitally acquired infection can often affect a child's length and quality of life, and we think specifically of congenital syphilis, but there are others. So both the mom and the baby must be considered when you are assessing women for maternal infections. Pregnancy is always regarded as an immunosuppressed condition because you have an altered immune response, and that may decrease the maternal ability to fight infection. Also, the genital tract has many changes during pregnancy which make it more susceptible to infection, the lowered pH being one of them. And advancing pregnancy causes the vaginal walls to engorge and the cervix to enlarge, and now the risk for ascending infection. So if we talk about infections of pregnancy, we want to look at the bacterial STIs, the viral STIs, and the genital tract infections. So if we start with the STIs, sexually transmitted infections used to be called STD, sexually transmitted diseases, but they're really not always a disease, they're an infection. So the definition of an STI is any microbe that is passed from one person to another through close, intimate contact. So we're going to start out with chlamydia. We're talking about the bacterial STIs, and you can see that my slide still has the old term there. It's the most common bacterial sexually transmitted infection. 3 to 5 million adults are infected each year, and it is transmitted by direct sexual contact or for the infant exposure at birth. It's very difficult to diagnose it, and it's often asymptomatic, and that's what makes it so difficult. Now remember, what is the most common symptom in women with a sexually transmitted infection? And the most common symptom is no symptoms at all, so often asymptomatic. If we look at infection during pregnancy, we're going to talk about what happens to the mom and what can happen to the baby. Mom may have a spontaneous abortion or preterm birth, or it could cause postpartum endometritis, the endometrium being the inner lining of the uterus, so an intrauterine infection. For the neonate, they're often low birth weight, and they're 10 times more common to be stillborn, and they're 10 times more common to have neonatal death. 1/3 of the exposed infants will have conjunctivitis, so the infection in the eye, and 25% of them will have pneumonia. So there's some pretty significant effects to that fetus. If we look at gonorrhea, it is also spread by direct contact with infected lesions and indirectly by transfer from inanimate objects, because the incubation period is 2 to 5 days, so it can stay alive on inanimate objects for up to 5 days. Symptoms: lower and upper urogenital tract infection, but again, usually only mild in women. So maternal effects during pregnancy could cause preterm birth, premature rupture of membranes, chorioamnionitis. Remember that the amniotic membrane is actually 2 tiny thin membranes slam dunk next to each other, the chorion and the amnion. So you have an infection of those membranes. Acute salpingitis, which would be an infection of the fallopian tubes, which could lead to constricture, scarring of those fallopian tubes, which can lead to infertility and arthritis. Neonatal effects, conjunctivitis, pneumonia, and they can have other infections. The nose, the pharynx, the ears, the vagina, the anus, and if they had an internal scalp electrode for internal monitoring, that can become infected. Syphilis, the incubation period is several weeks. And with the early infection, they may be asymptomatic. Remember, with syphilis, there are 4 stages of the disease, and so with that first stage, it mimics just having a cold or a flu, so people don't even realize they have it. And then that delays their diagnosis. And then when they go into the second phase or stage of the disease, it actually lays dormant. So it isn't until terrible symptoms in stage 3 that they often recognize it. Infection during pregnancy, women can have a late abortion, so late miscarriage, if you will, or stillbirth. For the neonate, congenital syphilis can occur, and that's when the spirochetes cross the placenta after the 16th to 18th week. What you'll see is they have constant rhinitis, so they are just runny nose. Cracks and fissures around their mouth. They may have hydrocephaly, and they get a corneal opacity. So in other words, they're born with congenital cataracts. Now, there is no residual effect to the fetus if the mom is treated adequately before the 5th month, because it doesn't pass the placenta until after the 18th week. So if she is adequately treated appropriately for the amount of time to actually kill the spirochetes, kill the spirochetes, then there will be no effect. I actually saw 2 babies that were born with congenital syphilis. I did a clinical rotation at Children's Hospital in Milwaukee when I was working on my master's degree, and saw these 2 babies, and they were some sick babies, and both of them died within a month after birth. So the life expectancy with congenital syphilis is very short, and during that time those kids are very sick. HIV, human immunodeficiency virus. Transmission of HIV is primarily through exchange of body fluids. You guys know that. The seroconversion occurs within the first 10 weeks of exposure. All women should be assessed for the possibility of HIV exposure. All women. And really with our gonorrhea, chlamydia, it's the same sort of thing, and syphilis, because you cannot eyeball these women. You can't look at one woman and say, oh, you look like somebody who we better test, or no, you look fine, because we just never know. And because the effect to the fetus is so severe, we definitely should be screening all women. So at the very first prenatal visit, they do cultures for gonorrhea, chlamydia, any other vaginal infection, and they do the titers for syphilis. However, the HIV is the one infection that we still need to get mom's permission to do. None of the other ones require permission. And so it's still a legal thing, and it has to do with all the psychosocial aspects around it, but it is obviously life-threatening to both mom and baby. So we really need to have a good relationship with our patients so that we can really strongly encourage them to evaluate it, because if we can find out that mom is positive and treat her immediately, we can greatly decrease that transmission to the fetus. The most common presenting problems for a woman would be chronic vaginitis and yeast infections. So repeated yeast infections. That would give you a clue to check for HIV, but like I said, all women who are pregnant should be assessed for it. So how is it transmitted to the fetus? Well, in the first trimester, it's transmitted to the fetus through the maternal circulation. But it can also occur with what's called inoculation or ingestion of maternal blood and fluids during labor and birth. And then it can be transmitted through breast milk postpartum. So the CDC recommends that women not breastfeed if they're HIV positive. And that is in this country. That is not necessarily the case in all other countries. But our CDC says this is one instance when women should not breastfeed. And obviously we don't want them pumping and giving the baby that breast milk either. Transmission to fetus is pretty high, 14 to 29%. Variables, there are some variables though that affect that transmission. What's mom's infection status? The lower her viral load of the HIV will decrease the chance of transmission. The lower her CD4 counts are will increase the risk of transmission. And how long have membranes been ruptured? If membranes are ruptured 4 or more hours before delivery, that will increase the risk of transmission in women who are not being treated for the HIV with medication. So what's our role in all of the infectious processes is to provide accurate information about transmission risk, not judgmental, but just to provide the accurate, very clear information. Advise women to practice safe sex during pregnancy and advise them not to smoke. Many of the infections, they increase their susceptibility if they smoke. Provide information on safety of the antiretroviral drugs for HIV during pregnancy because all of them potentially have toxic effects on the mother. Some of those things are neuropathy, cardiomyopathy, hepatic damage, increased triglycerides, and increased blood glucose. But the fetal safety must also be considered. And then we don't do this alone. We need to make referral to other resources, counseling resources, social services, our social workers, and elsewhere, maybe public health department, wherever else might be appropriate for them. Not hormone replacement therapy, but HAART, which is the treatment for women with HIV during pregnancy. Since the mid-1990s now, it's been quite a while, Jadovudine, which is Retrovir, alone was used before labor. That was given orally, and then during labor IV, and then it was given to infants for 6 weeks. It is no longer recommended in this country because they saw increased viral mutations and increased drug resistance. So now they have a combination therapy, and that's the HAART part of it, the HAART. And they use 3 drugs from 2 classes of antiretrovirals. Once a very low viral load is reached, lower than 1,000 copies per milliliter, the risk of transmission to the fetus goes down to less than 2%. So that's pretty significant. However, when we are treating mom with meds, we cannot guarantee that her newborn will not become infected. So we have to be careful how we talk to her about that. It's going to decrease that risk, but we cannot guarantee no transmission. Okay, human papillomavirus. This is now getting into the viral, HIV is a viral, but also human papillomavirus, HPV, is the most common viral STI. You have sexually transmitted lesions. These are the condylomata acuminata, which are actually genital warts. They're dry, wart-like growths. They have an appearance like cauliflower. They can be on the vulva, the vagina, the cervix, or the rectum. They're very, very difficult to treat. You can use cytotoxic agents and laser therapy. However, the recurrence rate is very high, up to 70%. And if they are so large, and I have seen them like this, they may obstruct the delivery. So they can actually block the outside of the vaginal opening. Now, we used to think that there were absolutely no effects to the neonate, and we now have seen babies born with these papillomas on their respiratory tract or on the larynx. So we do see that there is some effect now to the fetus. Other infections, other vaginal infections, TORCH. TORCH is an acronym that stands for these things. T is for toxoplasmosis. O is for other infections. Hepatitis is one of those others. Mono is also in there. R is rubella. C is cytomegalovirus. And H is herpes simplex. Now, these infections are capable of crossing the placenta and can adversely affect the developing fetus. And all of them will produce influenza-like symptoms in mom. So again, can be mistaken. Toxoplasmosis is a protozoan infection. It's associated with the consumption of raw meat and poor hand washing after handling infected cat litter. So cat litter can be infected with toxoplasmosis. In this part of the country, a lot of people like to eat what's called wild cat, which is a raw, very, very high ground, chuck or ground steak, but we recommend that pregnant women do not eat that because of the risk of toxoplasmosis. We also recommend that they do not change the cat litter. And I've heard some dads say, "What? Give me a doctor's sheet that says that you cannot do that." They think that they're joking. If the woman does not have somebody else in the home to change the cat litter for her, then we recommend that they wear gloves, and it wouldn't be a bad idea to double glove. Now, the fetal effects, there can be a spontaneous abortion with toxoplasmosis, and the maternal treatment is to treat her with sulfa drugs or clindamycin. Other infections, hepatitis A and hepatitis B. We know hepatitis A is spread by droplet, and the fetal effects could be a spontaneous abortion or fetal anomalies, preterm birth, fetal and or neonatal hepatitis, and intrauterine fetal death. When we talk about preterm birth there, I just want to remind you guys that probably our greatest risk for preterm labor is some kind of infection. Some kind of infection that maybe mom doesn't even realize she has, and it has caused irritability to that area, which then, especially if it's close to the uterus, can cause that uterus to become angry and irritated and start contracting. Hepatitis B is spread by the blood and body fluids, and your fetal effects would be low birth weight, prematurity, and they have a risk of later in life for liver cancer. Rubella is also called German measles. Now, rubella is transmitted by droplets from the infected person's sneeze, and we thought that we had pretty much eradicated rubella with the MMR vaccines, but we have more and more people who are not vaccinating their children, and we are seeing more German measles. Now, the big, huge issue here is that it can cause deafness. We see the fetal effects, spontaneous abortion, but the big congenital anomaly is deafness. And when we talk about there's a risk for it, we don't realize that with this infection, the risk is huge. It is huge, so it's a very high probability that infant will be deaf. My husband actually has a relative, a cousin, whose mom got rubella while she was pregnant, and that woman, who is now an adult, is deaf and has been since birth. So it's a high, high probability. Okay, CMV, cytomegalovirus. This is the primary cause of congenital viral infections in fetuses and neonates. Most of them are asymptomatic. I mean, most women are asymptomatic. The fetal effects will be hemolytic anemia. They can have jaundice, more over and above the normal jaundice, normal physiologic jaundice we see. Hydrocephaly or microcephaly can occur, and pneumonitis. And then treatment. There's no effective pharmaceutical treatment. We have to focus on treating the symptoms. So that's pretty hard. And then herpes simplex, we have type 1 and type 2. Type 1 is transmitted primarily by contact with oral secretions, and type 2 is transmitted primarily by contact with genital secretions. However, we cannot assume that type 1 is only found in the oral area and type 2 only in the genital area, because they can be found in both places because of the way that people have sexual activity. Now, transmission occurs when the person is shedding the virus. So remember, with herpes, it's a blister type appearance. So it looks very much like a chickenpox blister. It's called a vesicle. And as long as that is moist and open, they are shedding that virus, and that can lead to transmission. So unless the lesions are crusted over, then they're no longer shedding the virus. There are 10 to 40 million people who carry HSV type 1. Herpes simplex is one of those diseases, infections, that is a lifelong infection. You cannot treat it and get rid of it. Same thing with HPV. And that's why we now have the vaccine for the young girls, the Gardasil, to prevent the HPV infections. The symptoms with herpes simplex are much more pronounced with the first infection. So they're very, very primary infection. Symptoms are the most severe. And then later, with each subsequent outbreak, they'll have symptoms, but they won't be as significantly pronounced. Transmission to the fetus can occur via the birth canal during birth. And again, that risk is greater with the primary infection. So it is not transmitted to the fetus during pregnancy, it's just during birth. So women who have active lesions at the time of delivery need to have a C-section. And group B strep, we talked about this, I think, quite a bit in second semester. And asymptomatic colonization occurs in both sexes. So women can carry it in the vaginal tract, the perineal area, or the rectum. Men can carry it in their perineal area or the rectum. And it's just like Staph aureus on our skin, that we have no symptoms and it doesn't harm adults. Same thing with the group B strep. In adults, where they have it, they're carriers and it does not affect them. But vertical transmission from the mother to the infant occurs near the time of birth. 50 to 75% of the transmission occurs then. The most common cause is sepsis in the neonate, and it is life-threatening. I saw a baby die of group B strep within 3 hours of birth, so it is very life-threatening and something that we don't wait around for. So we try to prevent that transmission to the fetus by giving mom penicillin during labor. It's penicillin G. Let me see if I have something here. No, I do not have anything there. Okay, so it's penicillin G IV. She needs to get to the hospital as soon as she goes into labor so that they can start the treatment. She will get a dose IV and then another dose in 4 hours, and every 4 hours until she delivers. To be adequately treated, she needs to have had a minimum of 1 dose of penicillin G within 4 hours of delivery. So if she delivers in 3 hours after she's had that, it is not adequate treatment. And then we have to really focus on assessing the infant, and we may do some lab values and may even start that infant on preventative antibiotics, depending on the situation. So treatment does not occur until right before delivery, because that's when transmission occurs. If we treat her earlier, it just comes back because she's a carrier. So it has not been shown to be effective to treat her earlier in pregnancy. We need to treat her right at that time. Now, there is one other infection that we need to talk about, and that's the Zika virus. And so I will have more information for you as we get closer to class on the Zika virus. But this is going to end the class recording now on infections in our high-risk perinatal learning plan.